Welcome back to the ProPA podcast. I'm your host, Prof. G, and this is another episode in the MSK101 series, where we break down high-yield musculoskeletal and rheumatologic topics from the PANCE blueprint. In this episode, we'll cover giant cell arteritis, also known as temporal arteritis, a true emergency that every PA needs to recognize. We'll go over the patho, presentation, diagnostic workup, and treatment, and in the end, you'll test your knowledge with 2 PANCE-style questions. Let's dive in. Did you know that untreated giant cell arteritis can lead to permanent blindness? Early recognition and prompt steroid treatment are critical, not just for passing your exam, but for real-life clinical impact. So first, let's look at the kinder patho. What is giant cell arteritis? Well, it's a large vessel vasculitis that primarily affects the temporal arteries and other branches of the external carotid artery. It's immune-mediated with granulomatous inflammation of the vessel wall. The inflammation can lead to luminal narrowing, ischemia, and in some cases, vision loss due to involvement of the ophthalmic artery. It typically affects adults over 50, and it's more common in women and people of Northern European descent. All right, so how do these patients present clinically? Well, a new-onset temporal headache, often unilateral, is key. Patients can also get jaw claudication, which is pain while chewing, and it's classic and very specific. Patients also can get some visual disturbances, including blurry vision, diplopia or double vision, or sudden monocular vision loss. Scalp tenderness can also be present over the temporal artery, and they can also have constitutional symptoms like fever, fatigue, and weight loss. This condition is often associated with polymyalgia rheumatica or PMR. Look for bilateral shoulder and hip stiffness. All right, so how do we work these patients up? Well, the elevated ESR is often above 50, and we also see an elevated CRP. Temporal artery biopsy is going to be the gold standard for diagnosis. It will show multinucleated giant cells, intimal thickening, and inflammation. You can also get a duplex ultrasound of the temporal artery, and it may show a halo sign. Diagnosis is clinical. You want to treat these patients promptly and don't delay steroids for the biopsy. All right, treatment. We want to do high-dose corticosteroids immediately. This is going to be something like prednisone, 40 to 60 milligrams a day, or IV methylprednisolone if they have visual symptoms that are present. We want to start these steroids before the biopsy, although the biopsy remains positive for around 2 weeks. Taper the steroids over months. And then we also want to consider low-dose aspirin to reduce the risk of ischemic complications, and monitor for relapses and bone loss from long-term steroid use. All right, now let's look at the book med versus the street med. Book med is going to tell us the patient presents with that classic triad: temporal headache, jaw claudication, and vision changes, and we'll see an elevated ESR. A biopsy will confirm the diagnosis, and we start steroids. Street med, many patients present with vague complaints, including fatigue, headache, maybe some scalp tenderness. You need to be very vigilant. If the patient is over 50 and the symptoms don't fit neatly, but GCA is possible, treat first, biopsy second. All right, now let's look at some clinical pearls. So think GCA in any patients greater than 50 with a new onset of a headache or jaw pain. Jaw claudication is one of the most specific symptoms we can find. And an ESR greater than 50 is common, but CRP may even be more sensitive. Don't delay steroids for the biopsy. Vision loss is often irreversible. And 50% of patients with GCA will have or develop PMR. All right, now on to some PANCE-style practice questions to test our knowledge. Question 1. A 72-year-old woman presents with right-sided temporal headache, jaw pain when chewing, and blurry vision in her right eye. Her ESR is 92. What is the most appropriate next step? Is it A, order an MRI of the brain? B, start high-dose prednisone? C, schedule a temporal artery biopsy? Or D, prescribe acetaminophen and monitor? I'll give you a few seconds. The answer is B. Start high-dose prednisone. Remember, we want to treat these patients immediately to prevent vision loss. A biopsy can be done after the treatment is initiated. Question 2. Which of the following symptoms is most specific for giant cell arteritis? Is it A. Fever, B. New-onset headache, C. Jaw claudication, or D. Polymyalgia rheumatica? All right, if you said C, jaw claudication, you are correct. It is highly specific for GCA and seen in about half of the cases. All right, so some final thoughts. Giant cell arteritis is a diagnosis that must not be missed. Think of it in patients over 50 with new headaches, jaw pain, or visual changes. Time is vision. Start steroids early and confirm later. Thanks for joining me for another MSK101 Clinical Medicine Brief. Please don't forget to like and follow our podcast so you never miss an episode. And as always, this is the Pro PA Podcast, where future pros in medicine are made. Until next time, keep learning.